Welcome back. Hope you got more caffeine out there and ready for the next session. So, the next panel is called Moving the Needle on Health Equity. We are so excited to have Norma Martinez, who will be moderating this panel. Norma is a native of El Paso and a veteran of public broadcasting. She currently serves as a news anchor at Texas Public Radio and is the host of Fronteras. Fronteras is a program exploring the changing culture and demographics of the American Southwest. The stories examine unique regional issues affecting lifestyle, politics, economics, environment, and healthcare. Welcome, Norma. We are so excited to have you here with us.
Thank you. So we are going to be talking about moving the needle on health equity. And we have a very broad panel, as you can see. And the way we're kind of doing this, it's sort of an experimental sort of panel, but it could also just sort of devolve into just a regular panel. We have what we're calling a first wave of speakers and a second wave of speakers behind us. So we are going to sort of be moving the conversation from the front to the back, and then it's just sort of going to go back and forth. And we, of course, want to invite your comments and your questions. I believe there may be some note cards if you're shy about asking questions. I kind of like what was done in the previous panel, where if you have a question, you can raise your hand. They can bring you a microphone as well. That kind of makes it easier instead of coming to the front and moving all the people around you just to get to the microphone. So we won't be getting to the questions at the end. Just any time you have a question, I'll be alerted. Maybe raise your hand. I kind of get a bit of a glare, or maybe somebody will alert me that there's a question out in the audience. But it's a very interactive conversation that we're having here. So instead of me introducing everybody, I would like to have everybody introduce themselves on the panel, and also to give your title, of course, and a brief description of your organization. And we'll start with Beverly on my left, on your right. It's already on.
Testing? Very good. Good morning to you all again. It's great to be here to visit with you and to just share some experiences. I'm Beverly Watts-Davis. I'm with the Westcare Foundation, and I chair the Ella Austin Community Center. And so I am known as Mama B for the East Side. And so I focus in, and I keep my community always laser focused on the needs of our community. I mean, if you want to know other stuff about me, Google me. You can look it up. But because none of that's, that's stuff we've done, but it doesn't really speak to where we're going. And so my passion is to make sure that we have, in terms of the organizations within the East Side, that all boats rise. For 40-something years, I've been bringing in money. We've been working to bring in money to the East Side, and I've always done many grants and subcontracts, and never have I had an experience like we had with this, so I do know it's possible. Part of it is a trusting relationship. You got to trust the community to do what they do and to know that they will do it well. It can't just be a one-way trust. You got to be able to trust them, and they got to be able to trust you. And that's evidenced by, and you say that to them every time that you meet with them and you discuss what's going to get done and how they're going to get paid. So I just want to be able to say I'm glad to be here and glad to share the experiences and look forward to working with all of you all.
Good morning. My name is Nadia Mavrakis. I'm the CEO of Culturingua. We're a community-based organization that elevates and celebrates the people and heritage of the Middle East, North Africa, and South Asia. And we work in the medical center area, which has a high level of Middle East, North African, and South Asian immigrants and refugees, and we work to enable them to have the conditions to lead and live prosperous lives here in San Antonio.
Hello, I'm Dr. Lyssa Ochoa. I'm CEO and founder and vascular surgeon of the San Antonio Vascular and Endovascular Clinic. We founded the SAFE Clinic with the purpose of serving those zip codes in San Antonio that need the most help, and so the healthcare outcome we follow are diabetes-related amputations. We have 8 clinics, 3 on the south side, 2 on the west side, 1 on the east side, and we go to rural areas in Jordanton and Floresville. Our ultimate goal is to decrease diabetic amputations, and as we all know, that acknowledging the social determinants of health, which affects over 50% of healthcare outcomes, has to be addressed if we're ever going to move the needle on something like that. And so we use our practice as an advocate for the communities that we serve to try to not only provide quality vascular care, but to address those social determinants of health so that we can move the needle. And when we ever move the needle on diabetic amputations, which is kind of is the marker of the health of the community because it's something that is so preventable, then we know that everything upstream from that will have changed also. I'm excited to have this conversation with you guys.
Hi, Corin Reyes, Director of Health Equity for the YWCA San Antonio, where our mission is to eliminate racism and empower women, and we do that through our 7 core programs, which include childcare, youth services, economic empowerment, and of course, health equity, which I'm most proud of because that's my team. We provide a plethora of preventative services, and we do not have a clinic. We provide them directly in the community. We will go out to churches, apartment complexes, schools, wherever we can to bring preventative services to the community, low cost, high quality at all times. We will be opening our new Women's Live and Learn Center here in the next year, and we are super excited about that. We just moved out of our offices yesterday, and we're getting ready for full renovation of our campus where young women between ages of 18 to 24 with or without children will be allowed to live for up to 4 years for free while they complete their college education. So yeah, that's us, yeah.
I don't know how to follow that. My name is Paula Winkler. I am the director of South Central Area Health Education Center. We are a health workforce development agency that has a strong affiliation with UT Health San Antonio. I am so proud to be on this stage with all these folks because I hear about them all the time. And as a health workforce development agency, we want to increase the capacity of the emerging workforce to understand that the community does need their professional services in the community and not only in a clinical setting. So we're very, very proud to be here. We also work with a lot of folks in networks, activities, partners, any way you want to put it. But it's all about making a movement, not a deliverable. We want to make sure that when we rest easy, as our poet told us this morning, we rest easy with the fact that we've created a movement that increases the capacity of all of us to understand health improvement and health relationships and the networking that is equitable for everybody. So thank you for being here and being with us. Thank you.
And we'll start on the far end backwards. And Paula? Oh, can you pass your microphone back? Sorry. They don't have microphones back there.
Good morning. I am Joyce Turner, and I wear several hats, but I'm with Lyssa Pharmacy, and I am the director of the Equitable Vaccine Program. And also I represent Dragonfly 365. And the reason those two things are mentioned together, because oftentimes there's a forgotten community within the community. And I make sure to advocate for people with disabilities to make sure that in addition to us considering health disparities and inequities, et cetera, within zip codes, we have to remember that there's a sub-community within that community that they need us as well. So my goal is to advocate, and I think our accolades are unimportant. You can Google that. I'm a community member like you, and I want to make a change. So we have to be the change we want to see.
Hi, good morning, everybody. My name is Gloria Borrego Gomez. I work with Alamo Community Group. We are a local nonprofit in San Antonio that's been around for a little bit over 30 years now. We're a little bit different. We're not strictly health focused. We own affordable apartment complexes around the city. So we have learning centers within each of our apartment complexes where we host an array of different services for our residents. So we thought being part of this would be a great, just something great to be a part of so that we can, share knowledge that we learn with our residents about health stuff, because we're always looking to how to help them feel better. I'm sorry, I am so nervous. I've never been on the stage. Okay, I'm just gonna throw it that way now. Okay.
Good morning. I'm Mary Garr. I am the president and CEO of Family Service. It is a 120-year-old organization deeply rooted here in San Antonio and Bexar County. We serve clients across 14 counties today, to include Crystal City and Uvalde, where we've been for almost a quarter of a century. Our work is deeply rooted in addressing social determinants of health barriers and also understanding the impact that trauma, intergenerational trauma specifically, has on so many lives. We have over 30 programs and services that address challenges working from prenatal through older adult, a lot of focus on families. But when you look at those conditions and environments in which people are born, raised, live, work, play, and age that cause through systemic barriers and institutional bias, we work to help affect lasting change to break those intergenerational cycles of poverty, domestic violence, substance abuse, et cetera. Everything from programs in financial counseling and coaching and workforce development to educational programs and supports from babies up through adult learning, behavioral health counseling, health literacy programs, working with parent education, family strengthening, working to provide supports through our community centers, et cetera. Whole host of programs we do internally, but with many partners, including with some of you in the audience, because all of us together have to work to make the change to improve long-term health outcomes and create better life potential to all those that we work to serve in our communities.
Good morning, everyone. My name is Edward Castillo. I am the director of the Southside Collaborative. We're a new coalition focused on the south side of San Antonio, 281 and 1604, far south. Right now, we are a new coalition. We consist of the UT Health team, Ascension DePaul Services, Family Service, and Southside ISD. Our focus is to increase health equity, tackle the social determinants of health challenges and barriers in the community, and then to also improve health literacy, because that's a big component of health equity. We are currently focused as well on improving financial health for a lot of the community. And so what we're doing is taking a community of solutions approach to these, to come up with solutions, working with the community, people with lived experience who you don't always see typically working with professional experts or health experts. But we want to really make sure that we're bringing in the community to get that feedback and to get that buy-in to come up with solutions that are going to be long-lasting for the community. So everyone really working together and collaborating.
Okay, so we brought up health literacy, health equity, and these are all organizations that are doing so much in the community. And, I don't know if you're like me, where, we live our lives and we don't really see much of what's around us, but it's really eye-opening to me just how broad these organizations spread across the whole San Antonio community, and really the amount of need that is so paramount in this community. So again, very eye-opening to me, and this is just a sampling of what can be done with the Health Confianza project. And so I want to talk a little bit about why your organizations felt that you needed to take this extra step to be in the Health Confianza program. What was it that you felt that you could learn to better inform the people whom you serve about health literacy and improving the health equity facet of your organization? And I'll start with you, Beverly.
Well, what was very, very key to me is the fact that we were talking about health literacy and being able to get information out. When COVID hit, many people didn't know about it, and we really needed to make sure that people of color really went to get the vaccinations. And so we realized then we were able to put together a project. Literally, it was called COP. We called it our Community Outreach Project. But we were able to mobilize a group of women, black and brown women, and get on the phones and call people, and we got 8,000 people vaccinated in this city, when the city and the county couldn't get anybody literally to get vaccinated. And what it reminded me of is the fact that people had so many misconceptions about the vaccination. They're going to put something in my arm, and then they're going to track me forever, or because actually people of color have not necessarily had a good relationship, particularly African Americans, with the health system. So there was great distrust. But again, knowledge is power. Knowledge is important. And when our community doesn't have it, it really hurts us. And so because what was shared with me was about getting information out about staying vaccinated, keeping up with your vaccinations, how important it was to your health, so that we could begin to look at our health outcomes. And again, the east side, the 78202, 78207, have the worst indicators. We're not only the poorest zip codes in San Antonio, we're one of the poorest zip codes in the nation. And so with that comes so many other things that happen in our communities. We can't afford to not be on top of it. We can't afford to not take advantage of any and every opportunity that's out there to be able to make sure that our community is well informed and absolutely make sure that people know what they can do, that they get good information, and that we get them to take action on the information.
Well, I mean, that's a good follow-up because trust, I think, that's the big thing that we want to impart to communities of color who have had institutional racism for generations, and they're carrying that intergenerational trauma with them and that intergenerational traumatic memory that goes along with it. So when you have a population that has constantly been redlined, you've been experimented upon medically, I mean, it's so difficult to break down those barriers and to establish that trust. And I'll continue with you, Beverly. What did you feel that was that barrier that needed to break down that level of distrust against the medical community?
Well, one of the things is we made sure that the community did not think that this was UT coming into the community. And I have to just say that because, once again, I've been working with nonprofits in the East Side for years. So we know, one of the gentlemen said, Beverly, we're so used to people coming in and dropping in. Maybe what we should do is just tell them, come in, why don't we build you a statue so we can remember that you were here at one point. That was a great and telling comment. And again, we use credible messengers. Messengers, very key to lived experiences you spoke about, people who have lived to be able to talk to people. Our campaign was multifold. We got onto our community radio stations, our community television, where we believe trusted information is coming through. We went to our churches. We did block walking, which I don't know if anybody, but block walking, door to door. Here's what we want to be able to talk to you about. And we really use credible messengers to be able to do that. And with that, we recognize that the way that information has to get out, it really does need to come through credible messengers in terms of the organizations and communities. People believe, they go, oh, gee, that's a zip code, let's go over there and let's do work. So we're gonna drop in and claim that we're gonna help people, we're gonna pay ourselves, and then claim we're gonna help that community. And then we're gonna leave from there and go, what a great job we did. We have had that and please y'all, if I'm speaking wrong, please let me know that. But if I'm speaking right, please let me know that with your handshake. That's been happening for years. And now is the time, and we are all the ones to stop it. And honestly, this was a burden because, again, we were asked to do work and get reimbursed for work. And I wanted to remind you, slavery went out in 1865 when we didn't pay people for stuff. The model they set up was do this for us, and then we will pay you, which put a huge, for everybody that I talked to, everybody said what a horrible burden that was on them. Because when the federal government gave them money, they didn't say to UT, oh, by the way, we'll reimburse you after you spend it. So why would you pass that down to the very people in the areas you were targeting to be able to do that? So again, we chose to be a part of this because we have to. We needed it for our community. It was about our community. So we sucked it up, broke our piggy bank, did what we needed to do, got stuff done. And again, I think they're passing out information that of the things we did. The campaign we did would have cost, if we had paid for it, it would have cost $176,000. We got all of that, used our community credibility and our resources and our connections to get all this stuff done for the money that they gave us. well, for the money that they will at some point reimburse us for.
Does anybody else here on the panel, here on the couches first, and then we'll move to the back, have sort of a similar story to Beverly's, or any, or something similar to, or even different than? Anybody want to comment? Dr. Lyssa?
Yeah, so the reason we did Health Confianza program is the same. We serve those areas, all the zip codes you say, we are there, and we believe that we need to go to the community and be an integral part of the community to build that trust. And I think we all know that when you go to the doctor and we talk to you, you probably don't understand everything we say. And so be able to learn those lessons of how we can make our materials, our conversations, our interaction from front desk and ultrasound better correlate to a way that the patient can understand only helps for them to be able to better take care of themselves. And I can tell you when we first started my practice and we went to the southeast side, to the east side, to southwest, to the west side, one thing I heard from a lot of the patients is, well, thank you for coming here. If I had to drive all the way to your downtown even, it would have been a burden for us, but the fact that you come to us makes a difference. I've heard from we also have a kind of policy or a motto in all of my staff that we are here for the patient no matter what. And so from the first interaction, they call the office, when they come to the front desk, they see our ultrasound tech, they see our medical assistants. I have the expectation from my staff that we treat them like family and we treat them with respect and we show them that we care. And I actually have had patients come and tell me, like, this is the first time I ever realized that maybe a doctor actually cares. And it surprised me because I've been serving them a long time, but what I found with these patients is that when they finally get that connection, that someone that they trust and cares, that now their confidence and their ability and their motivation to take care of themselves changes. And so
one of the key things I just have to say, like in getting on the phone and making sure for people to have this information is so very important because we're talking about fundamental health. And, having to get somebody on the phone, it's like, Jeff, I understand you don't believe this. I changed your diapers. Get out here and get your vaccination. and being able to do this.
There's some tough love in there.
Yeah, that's right. I mean, that is sort of the role of community mothers. And again, I'm very thankful for the opportunity because the information was needed. We have got to stay vigilant upon this because it really is about preventative, not just addressing health, but making sure that we can do prevention so that we're not getting so sick, because when our people get sick, it's coupled with so many other traumas. When you are really sick and you can't buy anything and all you can afford is the cheap stuff that they're going to sell at the corner store, when you get sick and you got to choose between whether or not you're going to get food this day or pay the bill, or whether or not you're going to put your family in jeopardy of losing their house, we don't have that luxury. We have to make sure our people stay healthy. That's the most important thing. Prevention is the most cost-effective thing that we can do in our community. We don't have the luxury of not doing that.
I agree with you, Beverly. Prevention is the most cost-effective thing we can do. And what I have appreciated about the Health Confianza project is that it allowed us to bring in other aspects of our organization. When we say health literacy, almost everybody else in our organization grumbled at me when I tried to say, we're going to implement this as a policy. It's like, I work in HR, I don't care. But it allowed us to kind of force them to take a look at how every single one of their roles played a part in that most important part of health, which is the preventative measure. You should not be coming to see me or Dr. Ochoa before you've already taken care of the basic things like, are you eating healthy? Do you have good housing? And a lot of those problems come, down the line historically, and we really need to take a hard look at how we fix those problems so we don't constantly have pandemics and chronically unhealthy people with diabetes that we have to treat.
And I think also, Corin, good point, because, if you have somebody saying, are you eating well? What's your living conditions? Like, if you're going to feel, if you're the patient, that you're being talked down to, that you're being ordered to do something, and nobody wants that. They want a conversation with somebody they can trust, not somebody who they feel might be judging them. Can you talk a little bit about how you're addressing that at the YWCA?
Well, So the people that we hire to work on our team, we are clinicians, a lot of us. We have doctors and nurses. However, we're also community health workers, and that's kind of been the core of our program, is ensuring that everybody is entrenched in that model of community health work, because that teaches people how to address the social determinants of health in a culturally competent manner. Also, majority of our staff live in the community that we serve, so we understand what's going on there. I do not feel like if we went to the east side, we would be as effective. That's not our place. But I do know that I have a collaborator. I've collaborated with every single person on this panel at some juncture. And I can go to Beverly and I can say, that's your place. You take over this work from here. And we're really good at being where we're at. We're awesome on the west side. That's where we belong because we know that community. So, yeah.
We'll be getting to Nadia here shortly, but I'm curious, Paula, how is UT Health San Antonio sort of addressing all of this? You're kind of being seen as sort of the organization, the institution is sort of being seen as, the big mothership that some organizations might see as, like how Paula was saying, here comes UT into town and they're going to drop in and they're going to leave again. How is UT Health San Antonio sort of addressing that? How are you trying to really make other organizations believe that that you are here to help make a difference with the people whom they serve?
Oh my goodness, no pressure. All right. The UT Health San Antonio is full of very caring people, very caring faculty, very caring students, very caring staff, and a lot of times, just like everybody else, we all get involved in our own little neck of the woods. But when this came about, I was amazed at how all of a sudden we were getting outreach to say, okay, how do we do this? How do we pull this together? Jason came to us and he said, okay, Paula, what do we do? How do we do this? How do we connect this? You've been involved with the community. Your staff has been involved with the community. You've got networks, that you can work with. And, when we heard from Dr. Fauci that says, they asked Dr. Fauci, what do you need to get this going? And he said, we need a workforce that can really, really get to it. So how does that come about with what we already have? And what we already have is a strong connection with community health workers. I'm a community health worker. I think those are areas that are really, really strong, and all of a sudden, the Health Science Center recognized the fact that community health workers are more than patient navigators and more than connecting research to those folks. All of a sudden, it's to the point to where these are folks that really have the pulse of the community, and we've got to trust them. We already trust them. Let's go on and get further. And I think that, and I hope Jason would agree with me, and Dr. Bergeron was here earlier, would agree with me that within those community service learning activities, not only are we looking at how we increase the capacity of all of our folks to work together in an interdisciplinary way, but also how we can reach out into the community and be more authentic out in the community. And I hope that that's the path that this particular project has brought to it. And it's no longer a project, it's a movement. It's a movement.
So as we all know, San Antonio, Bexar County, primarily Mexican-American. We have a Black and brown community here, but we also have a very extensive refugee community. And so I wanted to talk to you, Nadia, about the work that you are doing, because it just seems like the refugee community right now is kind of being crapped on. I mean, Refugee Services of Texas closed, I believe, just last week. So those services are gone. And so these are individuals right now who are already facing, I mean, they're looking for housing, they're looking for work, they may have to rely on food banks. The health inequity in the refugee community here in San Antonio has got to be even more daunting than it was even during COVID. Can you comment?
Yes, and definitely the refugees that come here have experienced immense trauma. They've been forcibly displaced from their homes, and they've also, when they come here, are often under-recognized in terms of their needs. We have for example, many refugees come from the Middle East and North Africa, and Middle East and North Africa is considered white on the census, and therefore the data is unable to be shown that distinguishes or highlights what are their health needs. And then for the Afghan population, they're considered Asian American, but because that data is not disaggregated, it's very difficult to understand those needs. And so I think it's immensely important to partner with community-based organizations, as we've all been saying, that have those trusted relationships and have those language access. And so I'm grateful that Dr. Rosenfeld partnered with Culturingua for Health Confianza, because these are communities that are incredibly difficult to reach. Before Health Confianza, in January of 2021, Metro Health partnered with Culturingua to do COVID-19 vaccinations right at the beginning, when vaccinations were only available to 65 and older and chronically ill. And so we were able to do targeted outreach, and based on our trusted relationships, provide vaccinations and on-site interpretation services in Arabic, Pashto, and Dari at the Alamo Dome. And so when Health Confianza and the ambassador training was available, I immediately knew that this was something that was incredibly valuable for Culturingua's community navigators to get plugged into, so that they could have the continued training and understanding for how to communicate with the population that we serve, and then we also were able to partner with UT Health to bring COVID-19 vaccinations to the various community events that we've hosted for refugee communities. And because the refugees coming to these events that we host are coming for a variety of reasons, and then there's the COVID vaccinations available as well, and there's the trusted connectors, which are the community navigators that are able to not just interpret into the language, but more importantly, be able to communicate to them in a way that they understand, but that comes from the training that they received in the Health Confianza.
And I'd like to talk to Joyce Turner with Lyssa Pharmacy. You are people who are sick. They need medicine, so they have to go to a pharmacy. How is Lyssa Pharmacy, how are you helping to communicate health literacy to the individuals who are taking medicines? Because, a lot of us, we're given our prescription, we take it to the doctor, and it says on there when to take it, and that's pretty much it. And what kind of additional information are you and the pharmacy giving to individuals who might have questions but are too afraid to ask about the medicines they're supposed to be taking?
Well, I'll answer that one, and then I would like to piggyback on the other stuff.
All right, absolutely.
So, in my other role, I am a nurse practitioner, and I do house calls. And what I find is that patients cannot read. It could be because of low vision. It could be because of education. So one thing that pharmacies are doing, they have medi-dose packs where they will put all of the medication in one package, and you just have to open AM. And you don't have to be able to read for that because it's color-coded. Additionally, I educate as many providers as I can. Write your patients a letter that simply says, I am unable to read. Would you please explain my medication? It reduces the humility of announcing that this is a problem for you. Also, explain the medication in the language of the person. So I often hear, and this was new to me, I especially hear this in some of the Hispanic communities, for example, that they drink the medication. So I'll say, are you taking the medications? But for some of my patients, that's not the language that they speak. So therefore, I adjust to their language because at the end of the day, we need to make sure they understand. So pharmacies have ways to do this. However, they have to be informed that the patient needs it, which means the community health workers, anyone, the family need to be educated that they need to speak up because they don't. They're embarrassed.
Language, as you were saying, very important. You said, did you drink your medication? The Spanish word for drink is tomar. And so when, tómate tu medicina, it literally translates to drink your medicine.
Okay.
So it's a very good point. And again, language, so important in communication. And I know a lot of health providers in Health Confianza have been trained to speak speak normal language to people. We had on a recent Fronteras, we were talking about Health Confianza, and we were talking to Angelita, I believe her last name is Negron, with Empower House, and she was saying that they have to translate legal documents. Somebody dies in the family, what is probate? I mean, we all have to deal with it at some point, but I don't think anybody can really explain what it is unless you work in a court. I mean, you have to explain these things in detail in plain English, in Spanish, or whatever language that individual speaks. So again, language, very, very important. I'm glad you brought that up. I would like to talk to Gloria Borrego Gomez. Gloria, the people with whom you work, do you have that sort of barrier of language as well? You say you work, with a lot of apartments and with a lot of residents. How does that back and forth with the residents there go?
It can get a little bit tricky. We do have 3 staff members on site that are bilingual, which helps out a ton. But we do actually have this one property in the medical center that has a very large refugee property, and it's different. It's gotten a lot different from like 10 years when I first started there. There's a whole new bunch of languages like Pasha, hadn't heard of that. So we have a resident coordinator there who has taken it upon herself to really nose dive into to Google Translate or try to reach out to a neighbor who speaks a little bit better English to kind of help her translate to a parent if there's an issue with a kid, or if a parent is coming in trying to find a job type of thing. We try to find a middle person that already lives at our property. Sometimes it works, sometimes it doesn't. It's getting a little bit trickier right now. But I am so glad that you're here, because I'm gonna talk to you later to see how we can connect, because I think you would be fabulous to have on call.
For sure, and I just want to add that I think that I want to commend the city of San Antonio for investing in a language access office. The city hired a language access manager that they recruited from the city of Charlotte, and I like to say that the Charlotte mayor now hates San Antonio, and she has built a tremendous office and now has a language access plan that expands services that the city provides beyond Spanish and American Sign Language to now include 7 additional languages, and it's broken up into tiers, and that includes Arabic and Pashto and several others. And so I think that model and that leadership that the city has shown is something that is now being implemented with partners across the city and across the county, and I hope to see that additional investment in being able to provide language access to meet all the needs of the community members.
Any comments right now from the audience before we move on? Any questions, any comments? Back there, yes? Can you speak up, please?
I was just wondering, how do you get in contact or connected with language access?
Okay, how do they get connected with language access?
Are you asking for city services or in general, or can you clarify?
In general, well, we're a community health workers, so we work out of the Robert B. Green clinic, and we do work with refugees, and sometimes we're trying to find other ways of trying to find translators that you don't have to use through the clinic. So that's why we're asking, how do we connect our patients who are refugees, who are talking in Pashto, Dawi, and all of that, with language access.
Sure, and your work with the university? So I know that university got a big federal grant somewhat recently related to expanding language access, which is tremendous. And I think that that my recommendation for organizations that do have the funds to be able to have language access is to really invest in certified medical translators and interpreters that are in those target languages. Oftentimes, there's a prominent, I won't mention it, but there's a very prominent national language translation and interpretation service that is often used, and a lot of times those interpreters that are brought in on the phone, especially for Pashto, it may be someone that is from a neighboring country whose native language is not Pashto, but they say they can speak Pashto, for example, and then there's a lot of misunderstandings. And then the other thing is that there is really a shortage of female interpreters, and so I would encourage organizations that have the resources to be able to invest in interpreters who are native in those languages, but are able to be on site and be able to provide those services, and also go through the certifications of becoming a certified medical interpreter.
And key to that, something you said is that you do know that there's a big grant, but it's also really important for whoever receives that, the university or the city, for them to also not assume that the interpreters have to be over there in their offices and you have to go there and get that service. That they really think about putting people at the Y, at family services, that you take the resource that you brought and you put it out into the community so that it is accessible. That not that everybody has to come to you to receive the service, but that to think about that again as in partnering.
And I have to say also, there are way too many immigrant children or children of immigrants who have to translate for their parents. They have to take time out of school so they can go to their mother or fathers or guardians or aunts or uncles or grandmothers' doctor's appointments because they don't speak English or understand it well or feel insecure in communicating. And so I think having that access to a proper translator in various languages is going to also make a difference with young people who already just have the stress of being a young person from also being their parents or their grandparents' primary, care provider. So again, very important for these services to be available. And we have a question there in the corner.
Hi, I'm Ruth Berggren from the Center for Medical Humanities and Ethics. Thank you all for everything that you're doing and for the incredibly helpful remarks with the feedback. This is such an important dialogue. I wanted to speak up about refugees and translators. When you get to the bottom of it, health literacy is really about the language that we're using to communicate about health information. So this is maybe one branch of it, but it's core and central. There is a Center for Refugee Services that isn't closed. I believe perhaps, Norma, you were referring to the Migrant Resource Center that the city had put up.
Well, Refugee Services of Texas, they've closed all of their offices in the state, including one in San Antonio. That was what I was referring to.
And there is a small nonprofit,
there are others,
the Center for Refugee Services, which UT Health partners with. And we actually do have a weekly Wednesday evening refugee clinic. And we employ translators, medical interpreters who are certified. But it is our largest expense, and those interpreters are philanthropically funded. And so I would just make this point that the world is on the move. We're seeing more migration, not less. There's going to be more need for qualified medical interpreters, not less need, and it shouldn't be something that relies purely on philanthropic fundraising. And we need to think about how our institutions can structurally change so that that need to use plain language in the right language is accommodated. Thank you.
Okay. May I comment?
Yes.
I want to bring something up. Number one, a lot of us do not have budgets, but you don't need a budget for my point. So I believe in proactive approaches. right? So as the organizations that I partnered with, as we became a trusted messenger in communities who happen to identify as refugees, because these are people first, what we did was we made a proactive approach. First of all, we went to the communities with the trusted messengers, meaning people that look like everyone, understood the culture, right? We went there on purpose. We went in advance. And then we realized, oh my goodness, the community's coming to all of our clinics. So you know what? We, in advance, we invited interpreters. We thought about it in advance. The community didn't arrive and then, oh, we have to call a translator. We thought about that in advance. So one of the big things I would like to stress, when possible, be proactive so that people feel like when they arrive and there's a solution, you thought about me. I'm not an afterthought.
And again, this is an open conversation, so anybody, yeah, Mary, yeah, poor Mary hasn't spoken yet, so let's pass the mic back to her.
All right, I want to wrap a lot of comments into this, my part here. So first off, back to what Beverly said, you know, our health is the most important investment we can make in our lives. And we absolutely have to understand that, everything from physical, mental, emotional, but also financial, environmental, occupational, et cetera. It's our health individually, our families, and thus our communities. But too often, as was noted, when we're so focused on how do we put food on the table for our kids today, how do we ensure we can pay the rent so we don't get evicted tomorrow, we're not thinking about health because we're thinking about that. So it's how to move and understand that we've got to work as we are downstream with dealing today's problems. We've got to help mitigate and buffer on that. At the same time, working upstream to say what can we do to help prevent that for down the road and break these intergenerational cycles of everything that we're dealing with. And then at the same time, you know, when we're working with individuals and families that have been for so long marginalized and disenfranchised, they've been let down by the very institutions that are created and are supposed to be there to support them. You have to build trust, but how do you have trust when you've been let down so many times? So the time to build trust isn't after the fact, after COVID happens or after the next incident happens. You've got to be building trust up front. Who already has those trusting relationships? It's all of these organizations that are already so deeply rooted in the communities in which we all serve. So we have to partner together on that because we have that trust. Many of our staff at Family Service have that same lived experience. Several of them, a lot of them have been clients with us and with many others as well. They understand that. They come from the communities that they are now working in. So when the pandemic happened, for instance, we couldn't close our doors. We couldn't say, oh, we'll wait till it's over. We couldn't just say we added in telehealth and virtual classrooms, but we had to stay open face-to-face. The digital divide, as you know, is very real. But it's even beyond the digital divide. Even if they had access for a lot of reasons, they needed face-to-face supports and services. We kept all of our programs open face-to-face. They needed that. We had children. The school was their safe space. The schools were closed. So now they could come into our community centers and be safe during the day and working with them to complete their assignments and stay in school and work with their families. We found folks who were being abused at home, but we wouldn't have known if we weren't able to keep our doors open and meeting them in neutral spaces or bringing them in. You know, throughout, you know, with our promotoras, going door to door, knocking, not just leaving a flyer on the door, but having those conversations. And because they come from the neighborhoods, they're trusted. They speak not just the language, the culture, they understand. Those relationships existed before. They'll exist long after this. We have to understand, you know, our communities. We are part of the communities. We're our communities. So we've got to be able to work together on that. The institutions that are coming in, not just pass-through funding, but develop real relationships that exist beyond the current grant, but also develop the long-term strategies that we need to have if we're really going to move the needle on improving long-term health outcomes for San Antonio, Bexar County.
Well, you brought up a really good point that, I think every single one of us here can say that we have put our health on the back burner for the sake of work, for the sake of somebody else in the family, for caregiving. I think we've all done that. But there are communities where that has dire consequences. Now, another thing that we haven't really talked about is the shame that some people might have about talking about certain medical conditions. There may be women who don't want to go to the gynecologist because it's shameful to have somebody look down there, I'm thinking mostly women's issues because obviously, but, they don't, when they reach menopause, women don't want to be talking about the changes that they're going through. They don't want to talk about, vaginal dryness or, older adults don't want to be talking about, constipation to the doctor. It's just, these are embarrassing topics. And hot flashes. I get it.
Norma, the male Latino culture, also, we're in Uvalde, and so we have male adults that have not wanted to acknowledge their trauma.
Yes.
And so we do have male counselors down there from the community as well who are Spanish. One's a Marine Corps veteran, lots of tattoos, looks very masculine. But, he starts the conversations with them because their family members are dragging them in and they're saying, I don't need this help.
Yeah, because I was going to ask, how do you get them there in the first place?
Usually the family members. Yeah. And then they say, we'll just have a conversation. And by the end of the conversation, they're saying, okay, maybe I'll come back. And then they come back and they build that relationship. But yeah, we've seen patients, clients also that never come in. And by the time their cervical cancer is diagnosed, which is so preventable, they're going to die because of that embarrassment and they didn't want to say anything. Same thing, breast cancer, so many. I know Dr. Ochoa sees that every single day. We've got to break past the cultural stigmas as well.
Okay, but how do you do that? You need to have people not just talking openly about these issues with their doctors, but with each other, and nobody with the community, you need to be able to, destigmatize these issues. And usually the way to do that is through, on television, on the radio, on social media. You gotta put it out there until you're kind of desensitized to talking about that you haven't pooped in 2 weeks,
And you guys, one of the things that was really important that we're doing, we've been doing mental health first aid with many of the faith-based organizations in the African American and Hispanic community on the East Side. And so one of the things that has come up because of that, what has blossomed from that has been men coming together and women coming together. We call it sister talk and bro talk and teen talk. But the bottom line is that we have to normalize conversations about health. We have to make people feel it's okay to talk about what's going on with yourself, with someone. And one of the things that we did is we really reached out to our faith-based organizations because, again, particularly within the African American community, that faith leader is still considered one of our key credible messengers. And it was interesting to listen to some of the ministers say, Beverly, I can't talk about that. And I said, let me just ask you this. You're here, you're supposed to be getting souls for God, souls for Christ. I said, do you want to stand before God when your time comes and tell him that you had an opportunity to talk to your congregation about these things, and because you didn't, they passed on? I said, that's on you. And I said, do you really want to have that conversation with God when you get to heaven? And I said, you guys, this is all about all of us helping all of us in every way, and to normalize it. And that's what I was telling them. You guys, these have to be around the dinner, beauty shops. We begin to working with our beauty shops and our barber shops, that when people come in to start these conversations, training the barbers and the beauticians to be able to start talking about that when someone's doing your nails, the kind of conversations you have with somebody doing that. Some people tell the people who are doing your nails, more things than they will tell someone else. And y'all know I'm telling you too, because you're not going to miss your hair appointment, right? You're going to make sure you get there. But training them in truly mental health first aid so that they begin to, again, have those conversations with people. Talk about not just the soap opera, but the soap opera going on in your life with your health. Same thing. So I just think we have to normalize it, and we've all got to be much more key about doing that.
And sort of on the other side of the spectrum, we want to find a way to make health providers believe in what their patients are telling them. and not think that it's all in their head. How many, I'm thinking of, Serena Williams. She almost died giving birth, and she was one of the sort of the more publicly known women of color who almost died due to instances of postpartum or pregnancy-related deaths. These are very, very important issues, and a lot of doctors are not paying attention. Personal story: my mother, back in 1996, a couple of years prior, she'd had a complete hysterectomy. She had started feeling discomfort almost right away. She went to her doctor, said, doctor, I think you left something in there. Doctor said, no, all my operations are fine, you're great. She started getting inflamed. She started having bowel movements, bloody, dark red bowel movements. They sent her to get colonoscopy after colonoscopy. By this time, her colon had perforated. Nobody had done a scan. Finally, I would say she'd be about a couple of days away from death. I'm getting emotional here just talking about it. I'm pretty sure if she had not had emergency operation, she'd be dead right now. She would have been dead the next day. She had stage 4 ovarian cancer, but she's alive. She turns 92 on July 4th. But it took an emergency physician to say, crap, we let this go too far, because nobody believed her. So again, personal story, I'm sure you all have, felt the same. And so we've got to, get the communication going both ways.
So I'd like to comment if I could. And so you are right. And let's be real, we have had conversations. So let's just talk about women's health. So African-American women during pregnancy die 3 times more than a fellow white woman, and Latinas as well. And so when we look at us physicians and how we take care of patients, and we talk about, no one wants to say that we are racist, but there is definitely a system of racism that influences how whether they're believed, how we take care of them. And I know that a lot of medical institutions, and I know definitely UT Health is beginning to train the students as they get to residence on how do we listen to patients, be conscious of our unconscious bias. So, because it's real, you don't get to numbers like that without something being very, very wrong. And we have to talk about these hard discussions, and we have to look within ourselves, and we have to make changes. Because I'm sorry, when African-American women have a mortality rate during pregnancy greater than some third world countries, our system, there's something very wrong, and it is not okay. And so we have to fight to make those changes.
Norma?
I think.
Yes.
So bring this back into the pandemic environment. When everything shut down, that included our healthcare systems. And so patients who were known high-risk patients were shut out of care. And so it took months for things to reopen. And a lot of patients who had been receiving care received mixed messages about coming back in, or were still afraid to come back in. And we've got people who died, not because of COVID, but now they've been diagnosed with cancer, they've been diagnosed with heart disease, or they weren't being tended to during those times. I'm one of those that was diagnosed with cancer during the pandemic as an already cancer survivor who had a 7-month delay because I couldn't get access to my healthcare screening. When they found it, I had cancer, and it had spread to my lymph nodes, chemotherapy. I'm still dealing with all this today. But the National Institutes of Cancer, just for breast and colon cancer alone, estimate that over 10,000 Americans are going to die because of the pandemic due to having cancer that was not, they didn't get the diagnosis, the treatment, et cetera, during that time frame, and now they're dealing with the effects. We know that there is a lot of healthcare effects. Think about diabetes and everything else. People already struggle to access healthcare in our sadly fractured healthcare system, and this just put another layer on that, on top of layering with people who are already being marginalized and struggling to be served appropriately by healthcare systems. So we have a lot of things to work through
with healthcare systems to really put health equity at the forefront of what we need to be doing.
Can I say something?
Edward, can I, poor Edward has been sitting here. He hasn't said anything. So I want to see what you have to say. I mean, obviously we're seeing, a hospital shut down on South Side San Antonio. So obviously you're dealing with a lot of repercussions there on your side of town. What challenges are you facing because of what we've been talking about here today?
Yeah, definitely. I wanted to take a quick moment as we were having the conversation about making sure that we're talking about these things in the community. And I think for the Southside Collaborative and Essential Nepal Services and the partner agencies that I work with, that was one of the major reasons that we wanted to partner with Health Confianza, is because they have a community health club model that they do at school districts, that they do out in the community, where people can come together. They touch on different topics: COVID, misinformation, disinformation, mental wellness, all of these great things to start normalizing these conversations. Because I think that all ties back to empowering individuals to be able to go to these medical appointments and have that higher level of health literacy, where they can understand what the doctor's telling them, and they're empowered to advocate now for themselves and their family. So I think that's a very important point to make.
I think, Joyce, you were saying something?
I wanted to say something. You have to listen to patients. So when they say something is not working, it's not just about the lab or the x-ray. Listen to what people are saying. Also redefine what's going on. So with mental health, often I will say to someone who has diabetes, so let me ask you something. If your blood sugar was really high, would you take your insulin? The answer is yes, usually. So if your diabetes, if your blood sugar is high, would you take your insulin? If your blood pressure is high, are you going to allow yourself to have a stroke, or will you take your blood pressure medicine? And so that leads to, so let's talk about your mental health. So there's a chemical imbalance in your brain. Your medication will help balance those chemicals. That's a really oversimplified explanation. And oftentimes, a lot of times, I can convert people to take the medication because they're like, I never thought about it like that. I'm like, it's just your brain. It's like another organ. But taking time to listen to people, taking the extra measure to make a phone call, to make sure they get into that specialist, that's crucial to identify that cancer. Sometimes that's very important. Oftentimes it's required because the patient cannot get past the receptionist who doesn't understand the importance of getting that person in. So it takes the person with authority, like a physician, a nurse practitioner, a RN, a LVN, or whoever that can speak on a patient's behalf. And yes, it takes extra time, but time may make the difference to save someone's life.
And you all, one of the things you all, this is something that all of us can do. Think about the people that you work with, the people, your friends you're around. They will say things to you like, or you'll notice something that when they come in, they're not feeling well. All of us have to be actively engaged in each other's lives. And I know people think that may just be a busybody, but not really, because all of us observe our friends, our colleagues, etc. Things are going on in their life and we know something's wrong. Please be actively engaged enough and care enough about people. I tell people all the time, I care enough about you for you to curse me out, okay? Because sometimes I can get all up in your business when I know something is wrong. And look, we're not going out of here. That bruise on your eye, this is a third or fourth time I've seen that. I'm not leaving your office until we have a conversation, because that didn't just appear. And I'm saying that to you all because we've got to care enough about each other to be able to help each other. All of us, none of us get through life by ourselves. All of us got to care about each other just as we care about our community.
Okay. A few more audience comments here, but we haven't really heard too much from Corin or Paula or Edward, so I want to give you guys a chance to comment on a little bit of what we've been talking about today. Corin, what are some of what are you picking up here? What would you like to add to the conversation?
I'll sprinkle in a couple little comments just from things that I
Sure.
heard really quickly. Go back to health clubs. Yep, health club model is an amazing model. So we do a version of that called the Practicas at our department. We have one every month. Where women get to sit down and talk. There's a physician in the the room. There's actually 2 physicians in the room. We talk about uncomfortable things, even like constipation. They get to know each other, then they have those conversations, they take them back home. And that's a form of normalizing it. It's on a small scale, but it goes wider. And then back to the issue of doctors not believing their patients or the unconscious biases we have as clinicians. I wholeheartedly agree with that, but I also just want to sprinkle this in for everybody in the audience that puts a little bit of onus back on the patient, saying, oh, I just don't understand their culture, and that's the reason we're having these disparities. Because it's a lot deeper than that. We have systemic racism baked into the medical system so deep. Recently, they decided that the lab values that we use to determine kidney functions for patients, we used to use lab values at 1 for people, everybody else, and then 1 for Black patients. Well, we've been using that for years, and we've been putting Black people in stage 4 kidney disease for years because that lab value is based on no science. But yet we have, and I've used it, you've used it, we've all used it, and that's how deeply baked in racism is into the healthcare system. And if we do not health literate ourselves as clinicians to question all those things, then we are just gonna continue down the same path. Those are all my sprinkles. Paula, your turn.
My goodness. So what I'm hearing here over and over and over again, the word confianza means confidence, confianza, and we're having confidence in our health. That's what we're all talking about. And doggone, aren't we better together? I heard this before. Aren't we better together and stronger together? This is our sustainability sitting right here in this room. And we need to do that. We need to be a part of the process. We need to be a part of the solution. And I'm looking forward to the next step, moving forward, because I know that within this kind of conversation, we are very, very aware of everyone that's here, and we care. We care deeply. And we want to make sure that we keep that caring going on throughout the community. So everybody stand up and say, yes, we will be a part of this community. We will sustain this initiative.
Okay, Gloria, you've also been very, very quiet. I know you've got some comments cooking in there. What do you say?
So we participated in a couple of stuff. We did the pledge program. We did some other stuff with Dr. Rosenfeld, and we're really excited about starting the health clubs. So that's the next step that we're going to be taking within our Health Confianza journey. Because the same thing, a lot of our folks don't like talking about health, related topics. So we figured we put them all together in a room with people that they know and like someone that they really trust, like our resident coordinator. They'll open up more about issues that they have or just concerns. So we're really looking forward to doing that next.
We need to hear more from you, Edward. What's the step forward here with Health Confianza and what's coming up beyond?
So I think I would just have to echo what everybody's saying about the collaboration. I think that's a really big, important step that a lot of people overlook. Having worked in the nonprofit, sector for years now, I think that there tends to be a lot of duplication and sometimes redundancy. So I think it's important to make sure that us as leaders in our organizations, that we're taking that extra step to go to conferences like these, that we're networking, connecting with people, figuring out where that natural overlap is between missions and between initiatives, and then really spreading the money, sharing the money to make these things move forward. Because at the end of the day, unfortunately, there's not enough funding out there to fund all of our projects. So it's gonna take collaboration to make sure that we really have that sustainability to make a long-lasting difference in the community. And then I would just also really encourage people, as we're making these steps to move forward and creating these initiatives, that we really take the feedback from people with lived experience in the community, because it's so often overlooked. And a lot of the times they have a lot of great advice to provide and great solutions. They just need that encouragement and that empowerment.
Nadia, are you going to say something?
Yeah. I agree definitely on persons with lived experience. What I was going to say is also to recognize that there are a variety of racial and ethnic minority groups in the United States, some of which don't get the recognition at the federal level of the disparities that they experience. And I would encourage everyone in this room to support an inclusive approach to public health equity. And an example I will ask you all is related to the Middle Eastern North African community. I mentioned that MENA is considered white on the census and therefore is often erased in terms of the needs of the community. And there's a bill in Congress right now called the Health Equity for Middle Eastern North African Community Inclusion. And this would provide or formally recognize the MENA community as a racial and ethnic minority within the Office of Minority Health, and would also invest in disparity studies that right now are privately funded in order to truly understand the needs of the MENA community. So I also will ask you all if you would call your member of Congress to support this bill so that we can truly be an inclusive community and that we are addressing the racial and ethnic disparities of all members of our community.
Go ahead, Dr. Ochoa.
Yeah, I know we're closing, and so I want an overall message, and I do love to hear the same message everyone's saying. We all have to care about each other, even if it's not in your backyard. You know, we have to care about our communities that are our refugee communities, our underserved communities that don't have access. And we're talking about even able to have conversations with doctors, and there are communities that don't have access to enough doctors. You mentioned that we just had the closing of a Southside hospital. Right now, we have over 500,000 people on the south side of San Antonio with only 86 acute care beds and one small hospital. And if you want to talk about inequity, that is profound inequity. And so is the right answer just build another big hospital? I think that there's many things we can do. And it's investing in that community, it's education, it's Southside ISD, actually encouraging those students that they can become health providers of any sort, whether it's front desk, coding, building, nurses, and providing them those opportunities in education. Then we begin to build communities that fight and work for themselves. And when we give them those resources and invest at every level in education and access to healthcare, whether it's places to go or health insurance, and that's another topic, and support and encouragement, then we will begin to see how the communities themselves can foster when higher level policy decisions get implemented, but we need both. And so thank you, you guys, because all of you all realize that we have to care about each other and put action behind that caring.
Before we got a couple of comments back here, and everybody wants to comment. Okay, let's start over there, Joyce.
I just wanted to say a brief thing. One thing that, this was a question from the beginning, right? So Health Confianza was essential in every time we would have an event, right? Even if I wasn't the partner who was directly representing the health literacy, one of the partners did. So what was unique about what we did during COVID was every time we had an event, we had a resource fair. You know, it was informal, but we would have several partners there, multicultural. You know, we were talking about different things, you know, different inequities, offering, you know, how do you get a mammogram? How do you get food? You know, how do you find a clinic for X, Y, and Z? So I think that whenever you get the opportunity to get together, don't just bring your one organization. It's free to call your partners and bring everybody. Every opportunity is an opportunity to help someone.
Mary, you were going to say?
My wrap-up comment on this is that health and healthcare is a complex subject for even the most educated, even those in healthcare. So when we're talking about folks who have less education and are struggling with all sorts of day-to-day needs, it's even more daunting and puts even more barriers in front of them. So being able to provide health literacy and opportunities to better understand their health choices, make better informed decisions, and how to access and keep healthy, that helps everyone, our individuals, our families, and our communities that we serve. Knowledge is power on one level. Shared knowledge is much greater power, where we all work together on sharing our knowledge and making sure it's transparent so we can help, you know, make that level playing field and open book on the research and the science and the opportunities and the needs for people who want to work in healthcare, to people trying to access healthcare, to helping people stay healthy up front to begin with. But all of this together, the Health Confianza, and how do we sustain this moving forward, brings us together in, I think, new ways that we can really help open those doors. Thank you.
All right, so I know we started about 10 minutes late, so we're going to end about 10 minutes late. So we've got about 5 minutes to maybe take any comments. Yes, right here in the middle.
here at CareLink, that's our main goal, is to educate as much as we can. And whether it's a professional, clinical job, we're all health educators at the end of the day. But like I said, the biggest thing is I commend y'all because it's not easy what we do, especially like y'all mentioned, the care and trust portion. Being able to care and trust someone is the hardest thing because, like you mentioned, we all come from different backgrounds where we don't all have that trust in the healthcare. Me coming from the Valley, very close to the border, it's another thing, right? It's always, my doctor doesn't listen, my doctor doesn't want to. Being a health educator, you're being able to listen to somebody. And I speak for my grants here that we have here. That's our biggest goal when we talk about our grants and our outreach, being able to be that middle person for your patient, being able to be that middle person, because a lot of the times, like they mentioned, they won't come to the doctor to talk about everything. Why? Because they're so worried about, well, they're only gonna listen to one thing. They're only gonna listen to the few things that we have to say. So being able to be that middle person for these members, it's like a very heartwarming thing because they come to you for that trust, they come to you for that care that they normally wouldn't be able to come to on a daily checkup, for example. So, like I said, I commend y'all for what y'all do.
Any other comments or questions? I think we have somebody right over here to my right, to the left. Yes, go right ahead, ma'am.
Buenos días.
Buenos días.
Voy a necesitar un intérprete. Yo soy la doctora Arlene Mora. Estoy a cargo del programa de prevención de cáncer de mama en el YWCA. Para mí, voy a mencionar algunos elementos importantes y que realmente me preocupan. Corin, ¿puedes, por favor? Sí, ¿puedes por favor hacer el translator?
Yeah, I can definitely, yeah, let's do it. Okay.
Una de las cosas que más me preocupa es aquel temor que tienen algunos médicos. Yo en mi país soy médico, soy ginecólogo y me da terror porque muchas pacientes van a la consulta con un médico primario y no le palpan las mamas. Hay un gran temor de poner un dedo sobre las mamas de un paciente. Solamente piden una mamografía si el paciente lo solicita. Cuando hay un protocolo para eso. En Venezuela, que es un país tercermundista, nos guiamos por los protocolos de Estados Unidos. Y no entiendo cómo acá no cumplen los protocolos que ellos han establecido. Eso para mí es de gran preocupación. Otra cosa que me preocupa, perdón.
Okay. I think I got it all. Okay. Dr. Mora, she is our Women's Health Services Coordinator at the YWCA, and she's fabulous, by the way. She is a OBGYN from Venezuela. So in her country, when you go to the primary care doctor, if you're going to get a breast exam, and that's not common in the United States. We don't do that as a common practice. Women go in, they say, oh, you're 40, here's a mammogram slip, but neither teaches them how to do a breast exam themselves, nor palpates the breast during the primary care visit, which just leads to further issues down the road because it's not part of our primary care practice, and that causes her some discomfort. So,
and there's also that shame, right?
Shame,
oh my God, a doctor's gonna touch my bits, you know?
Perdón, no he terminado, perdón. Otra cosa que también me preocupa, no solamente en la salud de la mujer, es que, por ejemplo, una experiencia personal, mi esposo tenía una hernia umbilical, yo le palpo la hernia y digo, está complicada, es una hernia complicada porque ya tenía dolor. Va al médico, un cirujano especialista en abdomen, llega allá, yo no fui ese día, no podía, estaba trabajando, y él fue solo. Y le digo yo, ¿qué pasó? ¿Qué te dijo el médico? ¿Te examinó? Me dice, no. Yo entré, la consulta duró 7 minutos. Me dijo, no, mira, ¿por qué viene? No, porque tengo una hernia umbilical. Oh, ¿quiere que se la muestre? No, de aquí la estoy viendo. O sea, a través de su blusa, de su camisa, estaba viendo la hernia. Imposible, no se veía. Yo lo vi, no se veía. No le puso un dedo encima. Y adivinen cuánto les cobró. $590 la consulta y $52,000 la operación por ponerle una malla. Yo le dije, ve a Venezuela, yo tengo amigos cirujanos allá. En $2,500 te operan. Y a a él le dio miedo ir a Venezuela porque allá es un caos. Pero, o sea, yo lo que quiero es también, que me parece que es importante, considerando, otra cosa importante que me preocupa, considerando que San Antonio y todos los Estados Unidos actualmente es un foco multicultural, venimos de todas partes del mundo, ¿verdad? Hay gente de Afganistán, de Rusia, de Ucrania, de México, de Venezuela, ¿verdad? De todas partes. También hay que considerar que al momento de examinar a un paciente, hay que evaluar que ese paciente no es de aquí, no es anglosajón, que tiene otros criterios médicos, demográficos, estilos de vida diferentes. Y que, por ejemplo, si yo voy al ginecólogo, en mi país la citología o el Papa Nicolau se hace una vez al año. ¿Por qué? Porque tenemos altos índices de morbimortalidad por cáncer de cuello uterino. Aquí no, aquí es cada 3 años. Cuando yo fui al ginecólogo, al médico primario, perdón, me dijo que no me iba a hacer la citología. Y yo, ¿por qué? Porque ya se lo hizo el año pasado. Y yo, me la vas a hacer. Me la vas a hacer. Primero porque la estoy pagando. Y en segundo lugar porque en mi país se hace cada año. Y yo no soy de aquí, yo soy de allá. ¿Ok? Y por otra cosa importante es que en mi familia hay un gen dominante para cáncer ginecológico. Así que de aquí no me muevo con las piernas abiertas, de aquí no me muevo hasta que me la hagas. ¿Ok?
All right, for those of you who didn't understand, she's having issues with the gynecologist and her gynecologist wants to do an exam every 3 years. She wants it done
Pero
like now.
Es así. Okay, ya.
Okay, all right. And she was also telling a personal story about her husband who had an umbilical hernia. I mean, that's great because, she was making a really good point. And again, another personal story. And we got to wrap this up. I'm really sorry. But my dad, his primary care physician was, I think he was an endocrinologist because he had diabetes. And that was his primary care physician. My dad had also had hepatitis since like the 1950s when he was in the Army. And so, towards the end of his life, he did end up dying of liver cancer. But, I mean, you could tell towards the end, his eyes were getting yellow. He was jaundiced. He was already diagnosed with hepatitis C at this point. And he would go to the doctor. The doctor would ask him, "So how are you doing today, Mr. Martinez?" "I'm okay." My mom would go in there like, "Do you not see his eyes? They are yellow. Do you not see that he cannot give you a urine sample?" I mean, so you really, again, have to have sometimes an advocate for you there when you are at your doctor's office because, I think we've all done it before. "So how are you feeling?" "I'm okay." And inside the back of your mind, "But my back hurts, but my knee's been aching, but I've got this thing that's been itching for a while. I feel this bump." We've all been there. So we really need to have that advocate if we cannot advocate for ourselves. What we are at now, I think 11, I think we're a little past time. So I'm really sorry we can't get to all of your comments or questions, but make sure to pick the brains once we're out there during the breaks or if you see them during this conference. But I really want to thank you guys so much for attending this panel. I want to thank our panelists. You all are wonderful, doing amazing things in this community. We want to thank Health Confianza, all of the sponsors who've helped make this possible. Thank you. Thank you so much.
Hello. Wait, before you leave, again, thank you so much to our wonderful panelists here. This project is nothing without y'all. Thank you, and thank you to those of you providing comments and questions. Again, this is all a massive team effort.